Thank you.
Good evening to all. Then I wish to start this fourth day of 7 days workshop with the Charanam of Bharadiyar, one of the song of Bharadiyar. Akkini Kunjondru Kandeen, Adai Angor Kattilor Kondidai Vaithen, Vendu Thanindadu Kaadu, Thada Veerathil Kunjendrum Moopendrum. That means the simple explanation of this one is there is no small and big fire. Then even small fire or big fire that will destroy the forest, or that may be used for lighting Kuttuvilakku. Lighting Kuttuvilakku may remove the darkness from our life. But destroying a forest, that is that may be very hard moment for us. That means people and living things. So like that, we can gather knowledge. Knowledge also like that. There is no small and bigger. I hear this is very important to have the knowledge is searching. There is no small and big for searching also. Searching and researching will keep us in some other heights. With that sentence, I'll try to invite our guest speaker with the blessings of our founder chancellor, Dr. Kalonal JPR sir, and also with the great support from our management. There we have entered into the fourth day of 7 days workshop. Sir, I feel great pleasure in inviting Dr. Uday Kumar Kanniya, postdoctoral researcher, University of Montreal, Quebec, Canada, to give us talk on performance test methods for near-infrared fluorescence bioimaging. Sir has completed his MSc Physics in Bharadiyar University, Trichy during 2008-9. In between his MSc and PhD, he was working as lecturer in Pavendra Arts and Science College, Salem, in the year of 2009 and 10. He has finished his PhD in 2016-17 at Anna University in the field of biomedical spectroscopy and imaging. His dissertation title is Studies on the Characterization of Normal and Cancerous Tissues of Oral and Cervix using fluorescence and diffuse reflectance spectroscopy. He worked as junior research fellow in the Department of Medical Physics, Anna University, India, for setting up of laser facility in medical and technological applications. During 2016-17, he was working with two projects simultaneously as a postdoctoral research associate and also postdoctoral research fellow in Official Department of Bioengineering, University of Maryland, and Food and Drug Administration, called as FDA at USA, United States of America, respectively. At present, he is being a postdoctoral fellow at Tusain Justin Research Center, University of Montreal, Quebec, Canada, on the title of Characterization and Choroidal Thickness and Perfusion in Retinopathy of prematurity using in vitro and in vivo optical coherence tomography imaging. He has published 4 research papers in peer-reviewed journals. Here, he has presented 4 different research papers in selected conferences. He has filed the patent for redox imaging biopsy needle for breast cancer diagnosis. It was filed in 2018 at USA, United States of America. I invite sir to go for the valuable. Thank you, sir.
Hi everyone. First of all, I would like to thank Dr. Anandi and then Department of Physics and all the organizing committee members who gave me opportunity to present my work in such an international platform like Satyabama University. So I'm very happy and then being honored to be present in this webinar. And shall I start my presentation, Dr. Anandi?
Yes, sir. Please share your slides, sir.
Okay, yeah.
Yeah.
Can you make it full screen, sir?
Yeah.
Yeah, thank you.
Yeah, can you see it now?
Yes, sir. Yes, sir. Clear.
Okay. Okay. Hi everyone. I am Uday Kumar. So I'm going to talk about my various research projects that I have been worked during past 10 years on various timeline. So today topic is biomedical optical spectroscopy, imaging in cancer diagnosis. My overview of my presentation is I'm going to introduce my topic a little bit, and then I'm going to talk about my research projects, three of my research projects, which is the first one is multimodal optical spectroscopy for cancer diagnosis. So I have used various optical spectroscopic technique like fluorescence and time resolved fluorescence and diffuse reflectance spectroscopy. And then we use cancerous tissue samples or blood samples for normal and cancer patients. And then we'll try to diagnose whether using these techniques, we could be able to diagnose the disease, whether it's cancer or not. And then my second project is development of needle redox imager for breast cancer diagnosis. So this instrumentation is based on the fluorescence technique. So it's optical technique. And then we developed the fiber kind of endoscopy device to diagnose breast cancerous tissue. And then my third project is another optical technique, which is optical coherence tomography, which is a 3D technique. And then, so we are trying to image the retina of the deceased retina of the premature infants. And then I'm going to summarize all the research projects. And then I have a few things to add up with the presentation to talk about the application, or like how to get a position in abroad as far as the research domain is concerned. And here what you see is like I have 4 research projects. I will explain you one by one. So my first research project is fluorescence / lifetime spectroscopy for cancer diagnosis. So where you can see the fluorescence device, and then it will be connected by the fiber, and then there'll be a patient will be sitting here. So we will be shining an visible light basically, and then UV light, UV to visible range wavelength light, and then like the power will be very, very low, so it won't do any harm to the tissues. So so by shining the appropriate wavelength of light, we will get the fluorescence emissions of different particle inside the tissues, and then based on that we will differentiate whether this biomarker can able to differentiate between normal and cancerous tissues. So what we see is the oral cancer patient. And my second project is needle redox endoscopy for breast cancer diagnosis. So usually what they do is in clinical, when they want to take the breast cancer tissue sample for the diagnosing the cancer or not. So what they will do is like first they will use the ultrasound device to know like where the tissue is, where the diseased tissue or the cancerous tissue is. Once they find out the tissue, and then they have a biopsy device which is called a needle. They will insert the needle over here, and then they'll take out the biopsy sample. So instead of that, so we have developed a device called a needle redox endoscopy based on fluorescence imaging. I will explain you next slide what is fluorescence. So we will shine a light instead of ultrasound band here. So we will shine a light called a white light, and then we will collect fluorescence light from the tissues. And then we will later we will analyze the we can see in the real time basically whether where the diseased tissue is instead of ultrasound head. And then once we find the tissue, and then they will take the tissue out. So the advantage of our method, and then the objective of our this development of fiber endoscopy is that this fiber can go inside the can like scan on the outside of the breast, and then like it can go inside as well. So it does have like 3 millimeter diameter, and then like in order to avoid the normal tissue while taking out the diseased tissue for sampling. That's why we use that's why we have developed the fluorescence based endoscopy technique. And my third project is development of near infrared fluorescence imaging for clinical applications. So here, what I have done is I have developed the benchtop near infrared fluorescence imaging device, which is operating in the near infrared like 780 nanometer wavelength. So what I did is I have developed the device, like purchasing like each component, and then we set up our own near infrared fluorescence imaging device. So if you ask me like what is the applications of this imaging device, is clinically this device is used in the hospitals, like some of the hospitals, and what they will do is they will inject a dye called ICG, which is a fluorescence dye inside our body, and which is approved by US FDA and then like other international clinical committee as well. So this dye will go inside, and then they will shine the light. They will shine the light in the 780 nanometer wavelength, and then we will get the fluorescence emission in the 800 nanometer. So where we can able to see what's inside the tissue, and then what's happening inside the tissue when it is normal or when it is into the disease diagnosis. So this device is also useful for the to find out the any breakage of blood vessels inside the arm or inside our body. And my third project is OCT imaging. So OCT imaging is like it's kind of a three-dimensional imaging. It's widely used in the clinical applications. So what we see here is a eye. That's a human eye. So the A scan means that A scan is like one-dimensional or 1D spectrum depth versus the intensity. So what you see is like eye, and then it will pass through the lens, and then here it's lens, and then it will pass through all to the bottom over here, which is the retina over here. So it will scan the 1D spectrum, and then the B scan means that it will give you the 2D image, 2D two-dimensional image of the specimen that you are scanning. And then C scan means that it will give you the whole volume of the image. And then this OCT imaging can go deeper, like maximum like 3 millimeter or 3.5 millimeter, depending upon the wavelength that you have chosen. Because this OCT imaging available in the visible to near infrared wavelength. The wavelength that I worked on is mid infrared wavelength, which is 1300 nanometer. Let's see one by one. Excuse me. For some reason, I could not change my slide. Okay, so yeah, now I can get it. So we will see one by one. Before going into the my first project, which is fluorescence and imaging in cancer diagnosis. Let's see what is fluorescence. So the fluorescence is okay. So the fluorescence is nothing but like when we shine a light on any molecule, particularly like whether it's ranging from visible to UV to visible wavelength range. So what it do is like it will excite the molecule from the ground state to the excited state. And then where in the excited state, this will come to the intermediate excited state over, and then it will come to the ground state. Before the particle reaching out the ground state, it will release the wavelength of light, which is called fluorescence. So always the fluorescence emission is longer wavelength than your excitation wavelength. And then here what you see is like different fluorophores available inside the tissues. The fluorophore means that the particle which can able to fluoresce. So these are all the various amino acids and proteins, lipids present in our tissues, like tryptophan, nucleic that you see in the spectrum. There are a lot of things present in our tissues. So in my during my PhD, I have chosen 5 different fluorophore, which is tryptophan, collagen, NADH, FAD, and porphyrin. These are all the intrinsic fluorophore, which is like intrinsic fluorescence molecule present in our tissues. So I have chosen 5 of these, and then I used to we used to have the fiber, and then we have the wavelength range between 200 to 350 nanometer. So for each fluorophore, we will shine light, and then we will get the fluorescence emission. Later, we will analyze the data whether we can able to differentiate between normal and cancer. So it's give you the depending upon the intensity, we can able to see whether it's normal or cancer. So we can see the something called example. So this is what quite exactly happening inside our tissues. So when we shine our light, like blue light, um, and then we will get the emission in the longer wavelength, which is the green light. And then we have the more n number of mechanism happening inside the tissues that gives us the difference in the intensity of the fluorescence. So basically, like I have listed out like 5 different mechanisms. So it is like when the tissue is transforming into the cancer, so it will have like a epithelial thickening, and then nuclear become bigger, and then the collagen matrix which is become decomposed itself, and then higher microvascularization, and then high metabolic activity. So what you see in the right hand side image is you have the wavelength fluorescence emission versus the fluorescence intensity on the y-axis, and what you see is the spectrum for the tryptophan fluorophore. So if you see for the normal, the tryptophan, which is amino acid, which is high than the cancerous tissues, which is due to the higher metabolic activity inside the cells that will reduce the production of the tryptophan. That's why you see the higher in normal and then lower in cancer tissues. And the next technique which I have used is fluorescence lifetime technique on the oral tissue. So fluorescence lifetime technique is nothing but it is the extended concept of fluorescence. So we will instead of monitoring the emission, we are instead of monitoring the emission, we are monitoring the particle, how long the particle stays in the excited state, which is usually it will ranging from nanosecond to picosecond timeline for any particle. So we quantified the fluorescence lifetime of the molecule, which is in the excited state, how much time it stays in the excited state, how much nanosecond time it stays in the excited state. So what we do is like we have the tissue like normal here, and then we have the tissue like pre-malignant, which means that it is before the cancer stage, that like the earlier stage of cancer, we call it as a pre-malignant. So what we do is like we image 2 tissues, we calculate, we obtained 2 different decay kinetics, which is normal and pre-malignant. And if you see in the right hand side, if you see like in the tryptophan, which has a lifetime like 5 nanosecond for normal, and it is like 4 nanosecond for the pre-malignant tissue, and it is statistically significant. So sorry. So using this fluorophore, we can able to differentiate normal and precancerous tissues. And the next techniques I have used is diffuse reflectance spectroscopy. I think most people, the material science people, have been like well versed in this technique. So we have used this technique, applied this technique in the oral tissues, that is like in vitro biopsy tissues. So we do like a inpatient sampling as well, which is called in vivo, which is like we have a fiber and then we will do on the live sampling, as well as we'll take the tissue out of it, and then like we will measure the tissue as well. So here we took the tissue. So here what happens is that like we have the source fiber and we have the detection fiber. In the source, we will shine the light ranging from 400 to 600 nanometers, which is like white light, broadband wavelength. And then like inside, what's happening is like there are a lot of mechanism will be happening. Some part of the light will be reflected, some part of the light is refracted, and then Raman scattering happens, fluorescence happens, and then which are all these wavelength, these phenomena happens depending upon the wavelength that you shine, and it's also depending upon the hemoglobin content and all other particle inside the tissues. But in the visible wavelength range that you see in the right hand side, which is for the especially for the oral tissues, which is mainly affected by the blood, a higher absorption of blood in the visible range. That what you see in the dip, like in the 540 to 572 576 nanometers, is due to the oxyhemoglobin basically, and then we have like other particle as well, which is contributing to the spectrum. And here you see like cancerous tissue have the high reflectance than the normal tissues, which is basically cancerous tissues have like when they proliferate, the cells are proliferating, have the high dense of cells, and then nuclear become bigger and become like it forms a highly rigid, like highly tight structure. So that's how I think have a higher reflectance. And then below is the table like that shows like what are all the other fluorophores as well, giving the difference between the normal and the cancerous tissues. So coming to the conclusion, coming to the conclusion of the first project, which is like I have used so I have screened oral tissue normal and cancerous sample for the fluorescence. I have used fluorescence technique, and then fluorescence lifetime technique, and then integrating sphere, which is used for the diffuse reflectance studies, and then UV visible spectrometer as well. So I have concluded in my PhD thesis is that like which is the better diagnostic tool for the diagnosing cancer. So obviously like so through my research, so I have found out that like fluorescence device is better, can able to diagnose the oral tissue, oral cancer than the other techniques. And here I'm going to talk about my second project, which is novel needle redox endoscopy imager for cancer diagnosis. So this work has been carried out in the University of Pennsylvania, and then in collaboration with the University of Maryland, and which is in the famous laboratory called Britton Chance Laboratory of Redox Imaging, which is a very ancient laboratory, which is in the first time they have started this redox imaging worldwide. Actually, that's the first institution in the started. And then here that you see the image is the Chance Redax. Here he's the person who started this imaging device, which is this redox imaging is nothing but the ratio between the NADH and FAD, which I'll explain a little bit later. Okay, this is the right hand side. You see it's a device which is developed by him on 1966, and I had the honor and the privilege to work in this laboratory, like to work such a bold and an efficient instrument that they have developed in 1966. So we got inspired by this device, and then we wanted to make this device is for the application side. So previously it was not, it was used for the benchtop. So what I given my assignment is to develop the device kind of a compact the prototype model, which should be movable. The device should be movable and should be applicable for the screening of breast cancer patient, whether the tissue is normal or cancer, that we can able to see depending upon the fluorescence light fluorescence intensity of the molecule present in the tissues. So this is the device that I have developed, which is like kind of a busy slide. So what you see is that this is the fiber basically, and then like in the bottom here that you see is the fiber, which is like 3 millimeter diameter. And then you have two lasers and you have like different optics components. So all of them make together is the top view over here. And then this is the whole device. So this actually can be like movable. This device can be, you can put it in the trolley, you can move the device, and this is the fiber. And then this instrument is working based on the fluorescence technique. And then we have used like two fluorescence molecule, which is NADH and then FAD, which is why we are seeing here. And then like we will have the ratio of these two fluorophore called redox ratio. So this redox ratio will be used to, whether we compute it for the normal and we compute it for the cancer tissue. And then we will know depending upon the whether it's statistically significant or not. And the device that you see is the clinically available biopsy device. Biopsy device is nothing but which is used to take the tissue, for the sampling for further histology or further scanning. So this is the pink biopsy device, which is commercially available. This is the probe which can able to use it in the bottom actually. So instead of this probe, I have developed this fiber optic probe. So generally, how it works is we will first scan using this fiber on the breast tissue, and then we will see where to locate the diseased tissue by live sampling, live screening, and then we will see where we have the high fluorescence signal, because the cancer tissue like normally would provide high fluorescence signal, and then we will and then they will pass. They will inject this biopsy device, and then they'll take the biopsy, then they'll take the tissue out and for the further histological examination. And here is what we see in the right hand side. So this is the device that I developed, which is in the bottom. This is the one in the University of Pennsylvania that is the huge one, and this huge one is minimized or compacted like in this square platform. And this is another image of the instrument. And then we have used like the samples over here, like NADH, the fluorescence component, and FAD fluorescence components. And then like we will use these fluorophore to differentiate between normal and cancer after calculating the redox ratio. And we have filed a patent in 2018 as one of the faculty mentioned. So we have its patent pending right now. So we are hopefully waiting for the patent to be granted. And then once we develop the device, so in the material science as well, like once you have like some kind of device, or if you develop solar panels or something like that, so our next approach is to take into the market. We have to sell our ideas. So how to sell our ideas? So after developing our devices will be applicable for the clinical evaluation. So what happens in the clinical is like the current chain is like, first they will visit the exam, they will go to the meet the doctor, and then what the doctor will do, they'll take the biopsy, which is like taking out the tissue from the affected part, and then they'll send for the histological examination to know whether it's cancer or not. And then if sometimes like even for the experienced doctors, if they take the biopsy tissue, sometimes if it is not good, they have to take it again. So and then again you have to do histology examination. So this is kind of a routine step. Sometimes it will be repeated 2 or 3 times basically. So each time you have to pay $600 in, as far as the US market is concerned, I'm talking about. And then you have to again go for the $1,400 for the histological examination. And in our country, it's just like they're really very cheap than the international platform, which is very good. And then like what I have proposed is that like once you visit the doctor, and then using my device, instead of like calculating, instead of waiting time 2 weeks and for the histology, and all to put together. After 3 weeks, we will get the results whether our tissue is cancerous or not. Whereas here it will take 9 weeks, and then it will be minimized to, for using our device, it will be minimized to 3 weeks. So currently it will be like a portable one, and we are trying to make the device like more compact, and then like it will be sooner. It will be applicable to the hospitals, and then it will be applicable for the clinical trials, and then it has to go through the clinical trials. I think, which is the current phases is going on right now. My colleague is working on this project, so hopefully it will be come to the clinical market. And my second project is like performance test method for near infrared fluorescence imaging. So this project is supported by FDA, where I have developed this device, and then I have went to National Institute of Standards and Technology, NIST, NAST center as well, and then University of Maryland. So basically, my university is University of Maryland, and NIST and then FDA is collaborated with us to work on this to make this device. So before going into the project, so I make phantoms as well. So I think many of you have not familiar with this. Like, what is the phantom? Phantom is nothing but it's a tissue simulating material. So basically, it's a material, and then we incorporate tissue properties like absorption and scattering. And then if you incorporate absorption and scattering with respect to the tissue, then the tissue will then the material will be act as a real tissue, which means that it has to have the same absorption optical properties. So the usage of the phantom is that instead of testing the live mice, or the usage of mice or the humans, we can use the materials, to characterize the device, and to characterize any sort of organs as well. Like you can able to make the right hand side, you can see the real eye, which is the artificial eye that's a phantom, that they made by the other research group. So you can make like heart organ or like liver organ, and then you can study the function instead of killing the animals, or like sacrificing the animals for the, like for mice, or using the mice and then rat for the experiment. And here it's another fluorescence imaging, which is operating in the IR wavelength. Previously, we have seen wavelength in the visible range. This is the near infrared wavelength. And then we have, for this, we need external fluorophore, basically. So previously, we have used the internal fluorescence molecule present inside our tissues. So for this fluorescence imaging, we have used external component fluorophore, just fluorescence molecule, which is called ICG and fluorescein. And there are variety of fluorescence molecule available in the market, where we can use those molecule, and then we have to shine appropriate wavelength of light as an excitation, and it will gives you the fluorescence emission. And then it does have the localizing agent imaging, which is like for the PDT, like photodynamic therapy as well. They have using this drug to for the therapeutic treatment. And then we have a variety of molecular targeted imaging, like that there's antibodies, and then there are activable agent for the FRET, which is another technique, and then much more. And what you see in the right hand side is the elbow of the human, and then the ICG is the fluorescence dye injected into the body, and this is how it looked like this when you image the near infrared fluorescence imaging using ICG as a dye. And what I have did is like I have made phantoms to characterize the device. So what I do is like we will make different types of material, which is mimicking like a real tissue, and then I will use those material, which is called the phantoms, used to calibrate the device. So once you have if you have the device, then you need to calibrate the device actually. So this is the device I have developed this is a near infrared fluorescence imaging device, and these are the specifications. So clinically, there are there are many available instruments are available, like MRI, CT. Those instruments, they are clinically available device. They have a international standard routine protocol they have actually to calibrate the device before they operate. Every day they will kind of a check, like a quality check. They will call it as a quality check. So before they will apply it to the patient to image for the MRI or any other instrument, they will test the instrument whether the instrument is working or not. For testing the instrument, they need phantoms to test the instrument whether the instrument is working perfectly or not. So I'm making those phantoms for the calibrating this device. Currently, this device is available in the clinical as well, but there are no standardized technique or the phantoms developed so far. So one of our objective is to develop the phantom, standardized phantoms, which can be applicable to all type of instrument for calibrating their instrument. So once we have the instrument, we might need to know what is the sensitivity of the instrument. So when you develop any kind of instrument, so you need to know the limitation of your instrument, how much your instrument can be able to perform. So basically the sensitivity means that here, how much the lower concentration that this device can be able to measure. So for that, we have the developed ICG fluorescence phantom, which is what you see is here is the different exposure time in the cameras. And then here is a different concentration of the ICG, is the fluorescence molecule. That you see in the lower concentration, you don't see anything. And then when you started to see like 1 microgram per ml, when you started to see the fluorescence image, and then depending upon the how much time you exposure, like if you longer expose, you can see like higher lower concentration. So using these type of phantoms, we have find out we have a plot which is signal to noise ratio versus the concentration, and then we find out like limit of reduction, which is LOD. So we have a concentration like for the 100 millisecond exposure time. So that's the limit of reduction is 0.4. So depending upon the exposure time, we quantified the minimum concentration that the instrument can be able to detect. This is one of the parameters that I have calculated. So something like this, we have like a huge variety of parameters, like resolution of the instrument, and then here what you see is the depth, penetration depth. So you can see how much depth the near infrared light can penetrate, or how much fluorescence light you can see at certain depth. So if you see at a 12 millimeter, 12 millimeter range, you can see something. And then this is at the surface, 0 and 2 millimeter, 4 millimeter, like going deeper and deeper, you'll have loose signal, and then you have a high diffusion as well. And then so until 12 millimeter depth, you can able to see the signal. And that's what it indicates. It's like 1.2 centimeter. So you can see like higher depth. You can see the fluorescence signal, and then you have a signal to noise ratio, and then further full width and half maximum, like how much signal to noise ratio is enough to see the image is just like 12 millimeter is the limitation of the signal to noise ratio. Likewise, this is the penetration depth. Likewise, we have quantified for the resolution, we have quantified for the how much noise present in the instrument, or something like 6 different parameters have quantified. And then this research work has been published in this year in the Journal of Medical Physics, which is by the American Association of Physics and Medicine group. And what we have concluded is that we have identified like various image quality characteristics, which is as I mentioned, sensitivity, resolution, and the various performance characteristics. And some of the methods we took it from the literature, published methods, and some of the techniques we have developed. We introduced like 2-3 techniques that to make the phantom or to characterize the device. So we have used available technique, as well as we have used some new novel method as well to calibrate the device, to test the device whether the device is working or not. And this is my current project, which I'm working on right now, which is the preliminary development of the synthetic multi-layer phantom to study the retinopathy of prematurity via optical coherence tomography. So let me explain you they go through the presentations. Like I'm going to explain the context and problem that I'm going to working on right now, and then what we have in our literature, and what's our goals and hypothesis, and then my preliminary results on the mouse pups. Mouse pups means like a earlier age mice, like 12 days old mice, or less than 30 days old mice. We'll call it as a mouse pups. And retina, as you know, like the part of the eye. And then we have our concluding remarks and then future works. So our context and problem is retinopathy of prematurity. Like in simple, I can explain you like retinopathy of prematurity is nothing but one of the eye disorder that can happen for the prematurely born infant. Like premature born infant, which means that like it does have the baby have the less weight, or the depending upon the weight, or depending upon the uh, um, depending upon the month they born, it is considered as immature, premature birth. So during the premature birth, and then they will keep it as like in the clinical, they will keep it, and then like they will monitor the baby, and then the baby will be okay after a few weeks. Um, so what will happen when the baby born prematurely is that they are more prone to the disease called retinopathy of prematurity, which is the disease can affect the eye. So sometimes if the baby is not treated well after it's born, the immature baby, and then it will lead to the blindness of the eye. So it is highly important to know like what's happening when the baby's after baby is born in immaturely, and then we need to monitor the eye in order to know whether the disease exists or not. Current methods are not available to screen this disease earlier. I know, like they will find it in the second or third stage of this disease, and then they'll have a like routine therapy for the to cure the disease. So our aim is to we need to like we need to find the disease earlier, way before than the develop into the third stage or fourth stage. So that is our aim. So for that we have used different techniques. So our objective is like we will image OCT, which is optical coherence tomography. In the next slide I will explain what is that. And as we'll image mice retina, and then what we do is like I need to quantify the optical properties, and then I need to know the thickness of the layer, and then I am going to develop the same tissue mimicking eye using the external material called PDMS, which is polyurethane, and then we have the titanium oxide and barium sulfate. Most of us uh, have been well versed on these two components, which is like which I have used for the scattering. And this is the OCT imaging device. Basically, what you see is like we will shine light over here. This will be the sample, but what you see is the mice eye, the live mice, and then we'll keep it here, and then we will shine the laser light at 1300 nanometer, and then which is the enough. There is enough power which will not damage the eye, actually, the laser. And then this is what you see, the blood vessels in the top layer of the retina. This have like highly vasculature structure. So the OCT has like three different methods available, like time domain and Fourier domain. In the Fourier domain, we have like spectrometer based and spec source based. So this is working under a simple technique called in the PG you have done the Michelson interferometer experiment in your practicals. So this is the same thing happening, but some of the technique might differ. But as as a common, this is the techniques. Like what we do in the Michelson interferometer is that we'll keep one we'll have a mirror, and then we'll have a sample. We will keep moving the reference mirror not to get the interference fringes. When the interference fringes appear, then you will calculate the distance, actually. So that's what exactly happening over here. So when the interference happen between the incident light source and the collected back light source, then you have Then you have then you can able to see the tissue. Likewise, like you will move the reference mirror like back and forth depending upon the depth that you want to see. So so you can see for 3 millimeter, you can vary from 0 to 3 millimeter. You can move the reference mirror and you can see the image as well. That is what you see. Like with respect to the mirror, you will see the signal with respect to the depth. And after you take the Fourier transform, you will be able to see the what the real signal is. That is the simple optical coherence tomography device. And here what you see is the preliminary results for my retina. So this is like 7 days old mice retina, 17 days old mice retina, and 21 days old mice retina. So this is a development stage of 7th and 17th and 21 days mice. As you see, like the layers are not formed in the 7 days, whereas in 21 days the layers are fully formed, and you can see the highly blood vasculature. And this is a structure that you see in the right hand side. I don't want to go into so much detail into that. And this is the again is the image of the cross-sectional image of the retina that you see all the layers. And then this is the plot that you show, like what is the attenuation coefficient, which is the absorption plus scattering, which is the attenuation coefficient. What is the attenuation coefficient for the each layer? Then if you know the attenuation coefficient for each layer, then you can implement in the material to make the phantoms basically. So in order to develop the phantoms, we need materials like a PDMS. I have used it. This one is like inexpensive and then biocompatible. And then you can mold down to few nanometer scale. So what you see is that here you can able to like mimic like 10 micrometer or like 5 micrometer thickness of the layer that, you can go like as low as you can, like 5 micrometer. And then I've used titanium dioxide as the scatterer in order to get the signal, reflection signal. And then this is a protocol that I have used I have used a spin coating machine to have like a thinner layer where you can see the uncoated area have the transparent glass, where coated this is the coated material that with appropriate optical properties with respect to the biological retinal tissue. And likewise, I characterize like two different thickness of the layers that what you see right now. So you can I varied the spin coating speed, so you can able to see like the thickness is reducing. So I have so far I have characterized the phantom materials, and then I know like what how much thin layer I can able to make out of it. So the thinnest layer I made it like 15 micrometer. So the next step, what we will do is like we will make layer by layer by stacking, like what you see here. We will make a layer by layer stacking together to form this mimicking real mimicking eye tissue. That is our goal. And then later we will use this phantom to for the as I said, the diseased model. We will use the vasculature for the same disease model, and then we will see what we can whether we can able to diagnose the disease or not. And so yeah, the conclusion is that like we have imaged, like we can able to image like the mouse pups, and then we have quantified the attenuation coefficient, just optical properties, and then we have a preliminary results we have right now. And then in future we will develop like a real synthetic eye that mimic the optical properties of real eye, and that will be used for the validation for the disease. And my last slide is to share my ideas on like getting the postdoc position in abroad. So because when I get a postdoc position, like this is my second postdoc, so I was had so much struggle in getting the position because I didn't know like the methodology or like to know how to perform in the interview or something like that. So when you choose like when you go for a research position, not only for a postdoc or like share the research associate or something like that, when you work as a faculty, so you need to know like which lab you are choosing, and then like and then it doesn't need to be like all the qualification to be met, because like some of the labs here we're using high-end instrument and high-end technology that you have never seen, but you have worked on the basic methodology on the same field, so you can able to apply it basically. So it doesn't mean that you have to meet all the qualification, and also you have to know what all the research going on in their lab. Like any of the professors or like faculty who want to select, and then they want to know, like they want to know, like someone is contacting and he has to know like what is the lab working for. And then like you need to present with the confidence, like you need to have your work, and you have your basics. You should not afraid of like what they are having with the high-end instrument or high-end technology that they have. Like you need to present with your what you have and present with the confidence. And then like after that you need to write an email to the principal investigation or to the lab. And I have seen and many people are doing like they are forwarding the same content to the different professors, but the content will be the same. It's like a cloggy email, like all the things put together. It's a very kind of a long email or something like that. So whenever you write the email, so you should not write the same content. You should not forward the same content to the all the labs. You should go to visit the lab website, and you should know what the work is going on, and then you get all the information, and then you should make the body of the letter that should be precise. And it should not be, because he might have like fine time like 1 minute to 30 to 60-second time like to read your mail, just like what you have written. So you have to catch that time, like to precisely present your like what you want. And then these are the following things, like you need to mention the research accomplishment of the lab, and then like you should make it concise when you write the email. And then interview process is like as simple as that. Like don't make it things that you actually don't know. That's what I tell to the people. They come for when they ask for me, like for the interview, how to perform the interview or something like that. And then the proper internet connection, which is the crucial factor. So whenever you have a internet process or something like going on, so make it uses a proper internet connection. That will save many of the like mess around the interview process. It will be like clean and smooth interview process will be happening. And thank you so much for your kind attention. And thanks for the opportunity, Dr. Anandi, to present such an international platform. Thank you.
Thank you, sir. We have few questions posted by our participants.
Okay.
I'll just present it, sir.
Okay. So you want me? Okay.
Yes, sir. Are you able to see it, sir?
Yeah, I can able to see.
Yeah. These are the questions, sir. Participants, you all can also unmute yourself and ask the questions.
Okay, let me come by one. Like the first question, my research field is vibration technologies, fluorescence spectra techniques in India. These spectra are used for biologically active compound. Yes, the fluorescence technique, it is not only used for the material science people, and it is applicable like in the biology field, especially in the biophotonics or the cancer field. Yes, we are using a fluorescence technique. And then these spectra are used for all biologically active compound, which means that I would say no, because it is not for all the biologically active compound. The molecule which can able to fluoresce only can able to use this fluorescence spectroscopy. And why does the cancer cells exhibit more fluorescence than the normal cells? Because there are a lot of mechanisms inside happening when the cells are transforming into the cancerous one. What happens is that the amino acid level will increase, and then it has have the higher vasculature. The new blood vessels will be created, and then you will have more absorption, and then you have your structural your new tissue growth will be formed. So there are a lot of phenomenon is there to explain why the fluorescence is more. And What type of software is used? I don't know, like what, I mean, which software he's asking for. And go to the next question. Fluorescence spectra are taken directly from patient, or the damaged cells are removed, then spectrograph is taken. Okay, so the fluorescence spectra. So he asked like whether I have taken fluorescence spectra from the live human subject or from the tissue samples. Yes, I have did both. I have taken tissue samples from the hospital, and then I have taken separately as well, and as well like I have. So we have a protocol, like we will invite the patient to our lab, and then we have the fluorescence. We have the probe actually to shine the light on it. So we have used inpatient as well as we collected samples as well. What are the disadvantages or side effects produced? Disadvantages for there's a disadvantages of fluorescence technique is that like when you do the fluorescence imaging in the human tissues, as you can see a lot of as I have listed earlier, like you have like a lot of amino acid, lipids, and tissues have the like fluorescence characteristics. So what happens is that when you choose some molecule and that does have the particular excitation wavelength, and then like if some other molecule has the same absorption wavelength, then you will have like a problem with like having the fluorescence signal. So whether you can see the 144 or the like the combined fluorescence effect. That's the drawback. Can you tell me the minimum cost of diagnosing using fluorescence imaging technique as per dollars and INR? So I would not tell like I mean like as far as I know, I could not tell you what is the minimum cost because it is in the research timeline right now. So in every year, so even though the hospitals are using the fluorescence technique, that is not like standardized actually. So right now they are taking the tissue biopsy is the standardized one, and these are the additional things that they are doing it right now. So it is not coming to the market basically like to charge how much for the fluorescence, to image in the tissues. So right now it is in the research stage actually. It is not yet to the marketing or to the clinical stage actually. And your method is person compared to the conventional technique is expensive. Yes, yeah. The conventional technique will take 9 weeks. So we proposed 3 weeks schedule to know whether it's normal or cancer. So hopefully it needs like a lot of clinical trial and error methods. Is there any other shift in the wavelength? Yes, there will be a shift in the wavelength. Does this imaging diagnosis cause any of the side effects? No. Any molecular mismatch, right? Okay. That's the thing happening in the clinically, like molecular mismatch. Like same molecule, you have same excitation wavelength for two molecules, then you have a problem. Then you need to identify another way of like getting the fluorescence signal basically. I think I have answered that.
Yeah, yes, sir. Yes, sir. Participants, if you have any questions, you all can unmute your mics and ask the questions. Vijyanand, sir, I think so. You're online. You can come up, sir.
Can I?
Yes, sir.
Hi, Uday. This is Dinesh.
Yeah, hi. Hello.
Hello, hi. I had two questions. One is on needle redox method. What is the advantage over needle redox over that is MRA contrasting agents like T1 and T2? Because this is in vivo and this is in vitro. So what is your comment on that? The other one is I greatly appreciate your third one which is ongoing project. I like very much. That other thing, in that one question is, if you are sending 1000 and above nanometer of radiation to a retina part, how much is the localized heat is produced over there? If you calculate the localized heat over there, because it's a laser beam.
Obvious, yeah. Okay, yeah. Thank you, Dr. Dinesh. Thanks for your question. Yes, I would answer one by one. So your first question is, you asked about the redox imaging device, like what is the advantage over the MRI techniques. So the redox imaging device, what I have used is like MRI imaging, MRI imaging or the ultrasound imaging is like pretty much costly as well. And also like this device is like, we are trying to make, the first point is we are trying to make the devices cost effective. But so far, I mean, currently it is not the cost effective one because it is in the development stage. We have developed the device, so it has to go through the many phases that, you know, like at the final stage, you'll have the end product will be, which will be compact, like you can use it in your hand actually, with small device, you can use it. So for to reach that stage, it will take a long time. And
what
then
is the stage where you are in FDA?
Sorry?
In FDA approval stage, in what stage you are? Whether it in the, because we
It
say
is,
8 stages there.
it is not yet it is not yet approved. It is not yet applicable in the. We have not yet applied in the FDA.
Okay, got
We
it.
have filed the patent first, actually. Okay, so if we'll secure the our technical, technical drawing and something like that, and after that, it has to, we have applied for the project. Actually, the money has to be sanctioned, and then they will develop the device, and then 3 to 4 years only, like after 3 to 4 years only, they will apply for the FDA. In FDA, it will not be easily sanctioned. They have like a timeline like 7 years actually. So if you develop the device and you apply for the FDA, and you have to, like there's a timeline like 7 to 10 years you have to wait before the technique should be approved, because like there are thousands and thousands of instrument technique will be applied each year in FDA. So they will take more time to review like one by one, and then they will approve it. And what was your second question?
My second question is, in OCT method, you are using laser beam of about more than 1000, I think 1200, what you told, 1200 nanometer of light. I think. How much localized heat is produced over there? Because retina is more sensitive area. It causes localized heat there.
Yeah, sure. Yeah, that's a very nice question. Actually, it's a very good question, because like when I'm passing the 1300 nanometer laser actually. So yes, it does generate the heat actually that might affect the retina, but we have not yet quantified how much heat dissipation in the retina. Basically, I am working on the imaging side, and my other colleagues, which is like 2 or 3 people working on the other process, like material science people working on to quantify the heat or something like that, quantify the different mechanism, like how the heat is affecting, how the laser is affecting, how much bandwidth should we need to reduce, or like should we need to reduce the power, how much, those things are calculating by some other my colleagues. So the answer is the heat will be dissipated actually, but so far I have measured, like it is not yet affecting that much, because we are shining the light like 2 to 5 seconds only. And then for the OCT, for the volume scan, we have to expose to the more than a minute actually. So that will affect. Yes, it will affect, but we have not seen that worsening of the retina. But we are actually investigating those issues like in parallel, and then we will actually come up with a low power and then like to without affecting the retina or something like that.
Yeah, because we are also working with the Penn University only that to make the filters and radiation filters for cancer studies we are doing. I'm also working on that group. That's what I know about you. Say that's what I asked this.
Oh, that's so nice. So which thing
no,
you are working on?
I've actually worked with MG, that is the MD Cancer, so the Anderson Cancer Institute in Houston.
Yeah, that's very
So
famous.
we have one collaborator in Penn University. So he's working on the same filters that.
Oh, okay.
So I'm on radiation cancer physics. I'm working.
Okay, yeah, MD Anderson, like mostly like it is very famous for the radiation treatment. Yeah, that's something like the medical physicist or something like that, right? And
yeah.
You will quantify compute the radiation, and how much radiation should be passed through the tissue or something like that. I don't know like much about that, but I have
Hello. Great, actually. Great work.
Hello.
Yeah, thank you.
Hello, sir.
Yeah,
Yes,
hi, I
sir,
can
Vijay.
hear you.
Yeah, very good evening, sir. I am Vijay Anand from the Department of Physics, Satyabama University.
Okay,
Hello.
sir. Yeah,
Welcome,
hi,
sir.
yeah,
Welcome,
Go
sir.
ahead, sir.
Very informative session, sir. I have
thank
two questions. One is question number one.
please.
In the case of fluorescence spectroscopy, you have shown that there is some change in the intensity for normal and cancer cells. No. Sir, can you hear me?
Yeah, I can hear you.
Yes.
Please go ahead.
There is some change in the intensity. I am asking that whether there is any change in the shift in wavelength, sir, whether?
Yeah, the intensity changes. So what is your question?
No,
Whether
intensity changes means with respect to y-axis. I am asking that whether there is any change in wavelength, lambda.
yes, that's a good question actually. But for the plot that I have shown actually for the one fluorophore, which they have no change in the x-axis in the wavelength.
But what is my doubt is that whether it is blue shift or red shift.
It depends upon the fluorophore because the tryptophan that I have chosen, which has no shift, as you can see in the spectrum. Whereas
Okay,
if
because
you take like
you have mentioned that the cancer cells are very rigid in nature, no?
yeah.
So automatically there should be some change in the shift in the wavelength. No, that is my question.
Yes. Yeah. Your question is right, and then like your prediction is also right. There'll be a shift in the wavelength, but
Yeah.
which fluorophore that we are looking, there are plenty, like more than like 20 fluorophores inside the tissues. I have taken only one actually to show it to
Okay.
you. But for
Okay.
other fluorophores, yes, it does have the effect. Like either it will be a blue shift or red shift. So there'll be, it is like combining. It will be happening like for depending upon the fluorophore you have chosen. Some fluorophore have a blue shift, some might be a red shift. So so if there is a shift, then we have to depending upon the actually the chemical structure of the
Yeah.
molecule.
That is also the indication of the presence of cancer cells, no? Huh?
Yeah, that could be the indication, but yeah, we have to research more on that actually. I mean, we cannot say
Okay.
simply like because of
Okay.
shifting wavelength that means the cancer or something like that. We have to
Okay.
know the chemical, the material science point of view, like the structure
Okay.
and how it affects. Yeah.
Okay. Thank you. The second question is, most probably for the imaging purpose, you are saying that it is mainly based on absorption and scattering, no, sir?
Okay, so which imaging you are talking about?
That is your project number 3. You have mentioned no that the imaging is mainly based on the absorption and scattering of light, right?
Okay.
Due to absorption and scattering, there should be some loss of energy, no, sir?
Yeah. Yes. Exactly.
Due to that loss, it will affect the resolution of the image, How you are going to maintain the good resolution?
Yes, that's absolutely a good question. Yeah, when you shine the light on the longer wavelength, and then like we have so mainly the tissue will be affected, your image or image resolution will be affected by depending upon the, as you said, the wavelength, and as well as in the tissues, in the visible range, what you will see, like when you shine the light, it will be mainly affected by the blood actually. So blood will highly absorb all the light, and then you won't see any image in the, what you see in the fluorescence imaging or OCT imaging. But the wavelength which we are working is 1300, which is like mid-IR wavelength actually. So we can able to penetrate longer. You can able to penetrate longer depth, as well as like on that wavelength, the absorption of blood or all other highly absorbing molecule is very less. The absorption will be very less in the higher wavelength range. So we can able to have like more resolution when you choose higher wavelength than the visible wavelength.
Thank you, sir. Sir, the question number 3, mostly in the diagnostic purpose, we are using laser now, sir.
Yeah.
The most probably that exposure of laser is not good for the human, right?
Yes,
What
exactly.
is what is your suggestion for that power? What is the optimum power for that purpose, sir, diagnostic purpose?
So far for this project, I have not yet because since it's in the animal, the research is going on the animals like in the mice or rat. So we have not yet going to the second stage where we fix the power and everything. But yes, it does affect the high power, especially in 1300 nanometer, the laser. Certainly, it will affect the eye if you expose it for the longer lifetime, longer time. Sometimes it might burn the eye as well. I mean, the burnt tissue. That's what he is asking actually. So we are actually we are working on that. We are trying to reduce we are calculating the how much heat localized energy, or even previous people are asked the same question. Actually, we are working on that. Actually, we are quantifying the heat dissipation, because it does have a certain protocol to measure exactly like how much per millimeter area, how much heat is deposited. So that's a different protocol. My colleague is working on that. So we will make sure that it won't burn the tissue. Actually,
Okay, sir. Thanks for the clarification, sir. Thank you very much.
yeah, thank you.
Thanks for the organizers, all of you.
Thank you, Vidyanand sir.
Thank you.
Participants, do you all have any more questions?
Hello, yes,
I
ma'am.
have time permits one question.
Hello.
Go ahead.
Sir, I have one question.
Yeah,
Yes,
please.
go ahead.
అంటే అక్కడ ఎవరు ఉండరండి అక్కడ ఆ ఇంట్లో
Hello.
ఎవరు
Chita ma'am.
Yeah, yeah, I have few questions, please.
Yeah, please. Yeah.
Can I ask?
Yes, ma'am. Yes, ma'am.
Sir, good evening, sir.
Yeah, good evening.
దాంతో పాటు ఆవిడ వచ్చేసి ఉదయం మధ్యాహ్నం సాయంకాలం ఏదో పూట వచ్చి చేసుకెళ్ళిపోతున్నాయి కదండి ఏమ్మా అమ్మాయి కాకట్లేదేటి
Hello.
Hello.
Hello,
Yes, ma'am.
can you
Chitra,
hear
go
me?
ahead, ma'am. Go ahead.
Sir, few questions are with me. First question is whether all the force of the muscles are same or different?
Sorry, can you repeat your question?
All the muscles are having uniform fluoro force, or it will be the content will be different?
Obviously, the content will be different depending upon
Then error will be there, no, sir. Error, we have to consider the error, no.
What type of error, in intensity or something?
Because the fluorescence outcoming may differ with a different fluoro force in the muscles. So we cannot how to come to a conclusion that this is cancer cell or this is ordinary normal cell and all.
Yes, previously, yes, that's a nice question. So what we do is like, for if you image the skin tissue, especially on retina, you have a certain different fluorescence molecule. And then if you image with the elbow, like there are different parts in our body have a different content in the fluorophore tissues. So what we do is like we are focusing on the oral tissues, which is like inside the oral cavity. So we already know, like we have before concluding the remarks whether it's a cancer or not, we have going through the several research phase of like what is the normal intensity. Like we will have like variety of normal tissues, and then we will actually have the image. We will have the spectrum of all those different types of like 100 samples or 200 samples. Then we'll have a certain threshold level. Okay, this if it is crossing this much intensity, it will be a cancer or not. So we'll have the prior work actually for the more number of samples before concluding.
More number of samples, yeah.
Yeah, will be 100 tissue samples for the sake. Yeah.
Then next one is to get a higher level of fluorescence, can't we try with the X-rays or UV rays instead of visible rays? The fluorescence will be excellent in the case of the input radiation. When you give in the X-rays or UV rays, then the fluorescence will be more. But you are trying with the visible region only. Is there any speciality, sir?
So for X-rays, I'm not sure.
Because
like,
lower wavelength will give you better fluorescence.
But I'm not. So first, I will clarify the point. Like in biology, in tissues, the lower wavelength you go like in the UV or something like that. One is like it does have more components actually, and you will not see higher resolution. The optical, because it is highly absorbed by several
So fluorescence
molecules.
will be better, no, sir? Fluorescence will be better. We want to have a better fluorescence output. That will tell us about the tissues and all. We can study about the tissues. See, we want to have a better fluorescence. In that case, if you use the lower wavelength region, the fluorescence outcome will be better, I think so. We have studied biophysics, sir. So I am basically a physics.
Yeah. I mean, like, yeah. So we have variety of fluorophores, like 280 nanometer to the excitation wavelength, like to the 350 nanometer. So in between 280 to 350 nanometer, we have 20 types of fluorophores is there. So some of the fluorophores you have a higher intensity, and some of the fluorophores have like a low intensity, and some fluorophores you don't even see the fluorescence at all. So it highly depends upon the wavelength, and also it highly depends upon the which molecule you are choosing. And yeah, that's my answer.
Yeah, Suchita ma'am.
Hello.
Yeah, you can post your question, ma'am.
Yes, ma'am. Actually, I have one question only, sir. First of all, thank you for providing postdoc suggestions. Actually, this is very useful for us. And my question is that what about the development of phantoms using 3D printing for imaging? As is the 3D technology is relatively low cost technology for imaging?
That's a good question. So especially when you talk about the phantoms, I mean, you cannot avoid 3D printing because it is massively developing technology, like for the past 5 years.
Yeah.
So for the 3D printing technology, you can create like a complicated structure. Like when you develop the like a heart organ or like a liver organ, or like if you want to even develop a full mice, like the whole mice with the organs inside, you can able to do it with the 3D printing. But the point is like when you make a 3D printing, you can make it, yes. But the second question is like you need to, when you have the phantoms, you need to have a similar optical properties, which is absorption and scattering, with respect to the original or live mice. So some of the drawbacks in the 3D printing is that you cannot like control the optical properties of the material that you are feeding in for the 3D printing machine. So if you cannot control the optical properties, and subsequently you don't have the similar optical properties with respect to tissues, so that's a drawback of the that is the drawback of the 3D printing technology. But yes, the latest technologies are kicking in that does have you can able to control the optical properties. The latest technology 3D printer are available, but it's not like widely available. You need to choose, you need to go like, it is selectively available in the few places only. So there are options coming in, but hopefully like, it will be available more cheap, and then like we can use it for the 3D printing, because 3D printing like can create like a precise structure, like controllable, precise, and then like there are a lot of advantages in 3D printing.
Thank you, sir. I think so. Dr. Ajay Agarwal has some questions, sir.
Madam, it is a nice presentation.
Thank you.
But one thing is that technical difficulties arising over here, madam. We are not able to fill up the feedback form, madam. Excuse me.
Yeah, that you can post in the chat box, sir. Do you have any subject-related questions, sir?
That I have already posted, madam.
Okay, sir. Thank you.
Hello.
Can I ask one question?
Yes, sir.
Yes, sir.
Yeah. Uday, one more question. Sorry for this.
Yeah, I mean, please go ahead. I'm really excited to answer.
Yeah, I just got it now only that your SNR value is 3.
Yeah.
Okay, there's SNR value 3. If you are trying with that type of material, why can't you go with gadolinium oxide, with very good contrasting agent, which you tried on the second part of this thing when you are imaging purpose, no?
I mean, gadolinium oxide.
It's a very good contrast agent material.
Is it a highly scattering molecule or something like that?
Yeah, it's a highly scattering one, because it's worldwide it is using nowadays for a contrast agent. Like it's a very good contrast agent. And one more question. This is not question. It is a one small answer for the previous person. I think Dr. Chitra has asked that. Why can't we use the X-rays? Because I'm working on that area. I can, if you permit me, I'll explain that. A small answer that is.
Yeah.
Because this X-rays have a very high radiation. We are suffering a lot, because the side effect is more on X-ray fluoroscopy. And that is why we are trying to go for this type of IR radiation type of. But still researchers, even like us, are going for a low dose X-ray imaging technique, where we are going to use X-ray as a tool where image can be taken. That is the answer for her, because it's a very high energy, because we can't use for 5 kV or 6 kV. We use 60 kV to take images. 60 kV can create another cancer.
Yeah, exactly. Because since I have not worked on X-rays or something like that, so really I cannot like able to explain all and the questions regarding that on that field, because I don't want to comment on which I don't know. So I just skip that question. Yeah, thanks, Dr. Dinesh, for your explanation. Yeah, you are true actually.
Yeah.
Participants, thank you. You all have been posting up so many questions. I think so. Even if we continue the questionnaire section, we can continue even an hour. But due to lack of time, what do? We just post the mail ID and this video in your WhatsApp group where you can communicate to the speaker directly through mail. Okay, thank you, sir. Now we end up this session with a vote of thanks. Anandi, ma'am.
Thank you, ma'am. Science is organized knowledge, wisdom is organized life. With the blessings of our founder chancellor, Colonel Dr. JPS sir, in all the activities, always strengthen us and lead us in the pathway. I would like to propose a vote of thanks to our young and energetic speaker who plays with the body fluids and tissues. I would like to thank our management for providing the necessary support system for the best interviewers. I would like to take this opportunity to place and record our hearty thanks to our Dean, Dr. M. Sundareshwari, and Professor and Head Dr. S. Ravichandran sir for their constant encouragement throughout the program. On behalf of the organizing team from Department of Physics, I thank Dr. Udayakumar, postdoctoral researcher from Canada, for accepting our invitation. Thank you, sir, for sharing the precious knowledge on the applications of spectroscopy in the field of bioimaging, cancer diagnosis, both in vitro and vitro. Every great adventure in science has issued from a new adequacy of imagination. Your excellent presentation clearly picturizes the present scenario for research by evaluating the opportunity in the field of quantum layered structures. Thank you, sir, for your presence in our workshop today. It's interesting, informative, and interactive. I thank all the professors from the various colleges, students for your active participation. Thank you, one and all. Thank you.
Thank you so much for Dr. Anandi and everyone, the organizers, for giving me the opportunity actually. And I have like more delighted about like hearing all the questions actually. It's very nice interactive session that I had today. Thank you so much.
Thank you, Dr. Udayakumar. It was really interesting. We had even the participants were like in very interactive and interesting. Thank you, Udayakumar. And thank you even the participants. Tomorrow being the 5th day of our workshop, we have with us Dr. Sarat Chandra Virla, Associate Professor, Govardhani Institute of Engineering and Technology, Andhra Pradesh. He is about to present on the topic fabrication of nanobiomaterials for biomedical applications, and the session starts at 10:30. Thank you, participants. Sorry, we don't have session tomorrow. It's Thursday. We don't have session tomorrow. It's on Thursday 9th, day 5. And that's it. Thank you.
Thank you. Thank you, May.
Yeah, thank you.
Thank you. Thank you.